So, without wasting much time, let me start off with the basic idea of this panel meeting, which is to understand what the perspective of the end user is. That's what the focus is going to be. We'll look at some of what are the advantages of having digital technologies as well as newer innovations. But the most important thing is to understand what is the end user feeling about it. Let me start off with our technocrat, Mr. Saji. He is somebody who has taken Baby Memorial Hospital to the technological stage. I had a lot of discussions with him before the panel meeting, and I sort of understood that a lot of things that the patient sort of has an advantage when they come to your hospital. So what are the innovations that you are looking at in terms of new things that have come so that a patient feels even before they come to the hospital?
Good afternoon, everyone. Thank you for this opportunity. We have been using various technologies, especially digital technologies, in engaging the patients. So that's in various stages. That's prior to coming to the hospital. That's starting with the discovery. So you can use various technologies in terms of discovering the facilities and the doctors available in the hospital. Once you like, okay, you select that one, this is the doctor or the hospital you wanted to visit. So engaging them in terms of making an appointment electronically, making payment electronically. They come to the hospital, doing a check-in at the hospital using geotechnology, because when we use technology to capture the check-in time, so we wanted to measure also other parameters, what is the waiting time, how long they spend in the hospital. So we have using various technologies in innovating the experience. Basically, it is to provide a very delightful experience to the patients using various cognitive computing capabilities and various other digital technologies available. So basically, we use a chatbot in terms of engaging, that's a conversational AI, NLP technology, that's the natural language processing in terms of understanding the conversation, and the traditional approach of providing a web or mobile app. Now we have a kiosk also deployed. So that helps us in terms of scaling up immediately. For example, during the monsoon season, typically a day we have 2,000 consultations. If you do the over-the-counter service alone, we will not be able to, and we'll see long queue in front of. So we employ various channels and technologies using the cognitive computing capabilities also to provide better experience. That's in the post-hospital visit.
And what has, let me take it a little further in terms of chatbots you said. Like, is it something that is just a showbiz? That's what people try to understand, that you just go to a sort of a kiosk, and then has it gone beyond the level that it incorporates artificial intelligence or newer technologies into that chatbot and makes it more useful in terms of daily use of hospital services?
It's not just a hype or a showbiz. It is really providing transactional capability also. It's most of the chatbots came up with the inquiry, but what we have done is we integrated it with our core IT systems, that's the HIS and other systems, which gives the transactional capability. Basically, if they wanted to encover out a doctor, the NLP capability coming from, or the decision tree, it is just type a keyword in terms of using WhatsApp, maybe could be a friend end, or other any social media or social media messaging platform that can be in the front end, so which the users are very familiar with. So you integrate that with the chatbot, which is a AI-powered engine running in the background. So it picks up the keyword, understands the context, so then answers it. That is in terms of inquiry. Then you integrate with the transactional capability, booking an appointment, downloading your lab report, or finding a doctor, or making a payment. The transactional capability, which is capable of doing. This is capable of like scaling up to your requirements, because if you have people manning all these things, we know capacity. So here, the capacity is not a big challenge. So we can quickly scale up at the time of need. So that's how we use this.
Yeah, I'll come to Dr. Narayanankutty regarding, because you are running a large cancer institute, and you are the director. You have a lot of challenges in terms of implementing a lot of things. I think in the post-COVID era, there was always this hype, and I would not say the use of telemedicine. So people used to say that it is something that will sort of replace a consultation with a regular doctor. But there has been criticisms in terms of the utility of telemedicine. Do you think telemedicine really has caught on in terms of utility, and how has MBR Cancer Institute really looked at in terms of the purpose of telemedicine, and how is it going to go into the future?
Yeah, thank you, Praveen, for this wonderful opportunity. And telemedicine has really helped us in sustaining as well as contacting our patients who were totally isolated during the pandemic season. If you look at the growth of telemedicine, the telemedicine was the concept was nothing new. It was almost 50 years old, but the technology has really taken the telemedicine into clinical practice only from 2010 onwards. And till the pandemic, we were not very serious about the telemedicine. And many patients were totally isolated, and our oncology patients are very sensitive, and they require regular follow-ups and regular communication between the treating the oncologist and the patient. And I'm sure my colleague Dr. Boben also have a similar experience. So we were worried how to tackle the situation, because there are no ways to reach the hospital. And so that time, and also by the policy of the government taken for encouraging telemedicine, we could establish a telemedicine unit in our hospital. And with that, I think the telemedicine could help a lot of patients. From the point of patients, I see a lot of advantages for patients.
We know the 75% of the healthcare system, even in Kerala, is by private sector. And that too by medium and small size hospitals, not the bigger hospitals. So what all developments we have with the ultra modern facilities, this should reach the common man. So in that aspect, small and medium size hospitals should be enriched. With this view, I am the vice chairman of IMA PEPS, the division which deals with so many things for the small and medium sized hospitals, from job opportunities to medical equipment distribution to even ISAFE project was one of the projects we got a national award for the safety during the COVID times. And our one aim is to enrich this small and medium sized hospital with these developments. Because last 2 years back, when the COVID came, I am using software for the last 25 years or so. When I want to upgrade it, they gave me a special cost. That was 20 lakhs. Being a person with their EMR for last 25 years, the special cost was 20 lakhs. So how can a small and medium sized
that is one area that I want to focus on.
Yeah.
The technocrats, the people who actually are the end users are not everybody who can afford that sort of cost. So the people who are developing the apps and all the other things should also look at the cost factor in terms of a small size hospital. So is there a way out for this?
Yeah, what we have done is IMA PEPS is performing a networking of hospitals. What we are doing is, even for the software, we are going to have a software which will be for small and medium hospitals. That will be distributed to all the hospitals, and the patients will be given a unique ID card. With that ID card, they can go to any of the hospitals. That is sharing the resources. If one hospital is having a facility, let them, they are having a good ultrasound and ultrasoundologist. So we will send that patient to that hospital with its ID cards. They will get a special discount also. So the patient is benefited, the hospital doesn't have to invest much, and this goes to this common man. That is one field that we are looking. And in such a way, we are going to network all these hospitals with the sharing of hospitals, and also the data also can be shared through the networking of this software.
And initially, just like whenever there is any change in technology, there will be resistance. And there was a bit of resistance was there from the part of clinicians, because we all know that we felt that, okay, as clinicians, we are not technically that sound people, so that resistance was there. But once we started using it, we all realized that, okay, it's actually very, very user friendly, and then it saves so much amount of time. in different aspects we are actually saving time. Then now it has reached a stage where like whenever we are going to any hospital, when new hospital, we will be first asking whether you have got electronic medical recording is there. So from over the last 1 decade, from a clinician who was very reluctant to use electronic medical recording, now it has reached a stage where like we have started asking for EMRs. And the most important thing is about the safety of the data, which we actually mentioned. We all know about this, about the controversy that happened last year. It's regarding the sprinkler and all. That was all about the data safety kind of a thing. So the patient data needs to be highly protected. So whatever technology we are using, that the safety and the security of the data needs to be highly protected. So that part needs to be taken care. And most of the time, what I feel like EMR is very patient friendly. We always say like it is patient friendly, but the patients don't realize the value of actually this kind of a thing. For them, like it needs to be captured, whether you are capturing it in a paper or whether you are capturing it electronically, it does not matter. But they don't understand the value of what we are actually doing. The most important thing is that when a patient comes to an emergency department, the emergency doctor who is sitting here that has got absolutely no clue of what was the medical history of the patient, and trying to get the file from the MRD and then getting it back, it takes so much amount of time. But if it is an electronic recording is there, at one click the entire patient's details will be there, and the clinician, that may be a junior doctor who is sitting in the emergency department, he will be able to get access to all the details that has been happened, and then he can call up the consultant in the middle of the night, all the data will be there. So that in that way also the patients are actually benefiting. It's not the doctors or the clinicians who are actually benefiting, the patients are also actually benefiting out of this thing.
Yes, Dr. Madhu, yes.
Yeah, one more thing. During the last COVID period, what we have seen is general patients are not happy with the digital consultation. In Kerala, people are not happy. They should go and see the doctor. So in whatever way we say, the common people will be happy to have that personal consultation. And the personal consultation also is very important, because now we are moving digitally, but that touch of the patient is very important, that we should not ignore. And what we have seen is instead of that high-tech forms, everyone is having the mobile. So mobile consultation or WhatsApp consultation they are accepting. So that way we can promote a lot. They'll be accepting WhatsApp consultation. Even payment they will also be doing it through WhatsApp.
Replaced by AI. And he quoted AI as an augmented intelligence rather than artificial intelligence. With this in mind, with a wide spectrum of audience here from IT, from healthcare professionals and hospital administrators, let me just, my specialty, I'm a gynecologist basically. I'll just quote an example. Just like we have got ECG, we have got a CTG to monitor the baby's heart rate. If you get a CTG strip and give to 10 gynecologists, 5 of them will not have any doubt, it is normal. The other 5, there is some doubt with the same CTG tracing. Some might say it is a little abnormal. Some might say I'm a little doubtful about it. And some might even say it is abnormal. So the same trace given to 10 different people, the analysis is going to be different. That's exactly where AI comes in, where human error comes in. See, every time of the day we are not the same. So many things affect the way we diagnose things, even if the same patient is sitting in front of different people. That's exactly where AI can augment our healthcare system. Of course, as the other panelists said, the speed, the time of the healthcare professionals, the doctors, nurses, how much time we spend with this. And the data analysis, the same data of 10 patients, if you have to manually analyze, it will take a lot of time, but AI will come in there. And with all the imaging modalities of the modern era, the CT scan, the MRI, with all the algorithm which is attached to it, things are much different. But again, remember, see, our second part of the topic is impact on patient experience and care. Just like Madhu sir put it across, how we communicate, whatever diagnosis we make, the patient does not mind. How we communicate, that touch really matters. And we challenge the technologies sitting here. That part, if you take care, our healthcare system is going to improve.
Yeah, well said. Coming to diagnostics, I believe oncology is one area that is always in the cutting edge in terms of diagnostics, and to a certain point at least there is some replacement of our intelligence by augmented intelligence or artificial intelligence, whatever you want to say. Dr. Boben, you have some experience with using diagnostics and sort of having rather than, there are people, as in tumor boards, you always have a lot of debate in terms of whether to go for that treatment or this treatment. Whether it is possible to have sort of an objective assessment and an opinion from an artificial source and go on with treatment. Is it possible?
Yeah, definitely we have actually moved into that area, because if you take the case of any malignancy which you're taking, there was an era where we used to treat based upon the histopathology report alone. But now that's not the situation. We have to go into the molecular biology of the disease, and now we are actually moving into the next generation sequencing. So any patient coming with a malignancy, we will not be starting the treatment. I mean, most of the patients won't be able to afford the modern technologies. That's a different issue. But at least the technology is improving in such a way that we are actually going into the molecular biology of the tumor, assess the molecular abnormalities, and then based upon that thing, we are actually starting the treatment. And the cost was a prohibitive factor, but then we all know that when it comes to technology, over years, the cost will only come down. It's never going to increase. Newer technologies will come, but older technologies, it will only come down. The simple example is we are taking case of lung cancer. Previously, all lung cancers used to be treated in the same way, but now we know that if we have a patient with lung cancer, we should do the molecular biology. And the most common abnormality which we see encounter in lung cancer is something called as EGFR mutation. So earlier the technology was very expensive, but now we can able to find out whether the patient's EGFR gene is mutated or not with cost of less than around 2,500 or 3,000 rupees. And the turnaround time also reduced. When I started my practice, the turnaround time was almost about a month, but now within a couple of days, within 48 to 72 hours, we will be able to get the data.
I want to ask you about this IBM Watson. That was a sort of a technology that was proposed to replace an oncologist.
So what we have done in our hospital is, okay, what we could see is maybe 50% of the patients who is coming maybe tech savvy. So even at the kiosk, we have people who are ready to assist. The advantage of using a kiosk or over the counter is, in the kiosk, if the patient is with the agent, then they could see what is being typed. So it is the whatever data out of patient registration captured is error free. Whereas sitting in a counter, your screen is in the opposite direction, they don't see. So whatever they talk to the agent or the executive, so that will not be captured correctly. So we can expect whatever technology, apps, or whatever we say, WhatsApp. So maybe it will only capture to half of the population. The remaining we need to take care of the elderly people or maybe the children, all those things, those categories. So when we implement a strategy, we need to look at the end users in mind, and we need to adopt appropriate technology for the appropriate age group. And coming to the doctors also, the most of the clinicians that we interact, they blame the technology also for taking away the natural interaction they had in the past with the patients, because now most of the time during the consultation you are staring at the screen rather than looking at the patient. So the
human touch is
gone.
The
touch and the look, those kind of, that is a feeling, the human sense, that is losing. So we need to use the same technology. That's a challenge before the startups. How can we use the technology to overcome these barriers? Because it's maybe with the natural language processing, the sensors, and the video, so the video analytics, all those things, we will be able to replace that. So the natural interaction will happen. In that process, all the medical records will be captured. The conversation, from the conversation, morning we heard about it. So from the conversation, the text can be captured. From the posture and other gestures, you will be able to understand whether what they are talking that resonates with the actions. So we will be able to use the technology to bring back that natural interaction. The doctors will be happy, and we need to look at the end user. So we have to, from an end user person, it should be user friendly. Whatever technology we adopt, it should not be for the sake of technology. It should be keeping the end users in mind. And also some of the best lessons we learned is, you understand your stakeholders, you partner with your difficult stakeholder from the beginning rather than leaving them out. They may be going and propagating negatives, or rather engage them from the beginning. And also in this process, not just doctors or clinicians alone. In our hospitals, we empowered even the attenders. So with the smartphones and mobile apps. So it's last care of people also. When you empower them, then positively touch the ego of other higher up people, they will also start adopting technology. That's some of the best lessons we learned.
One thing is about, we say that we give a gift of life to patients.
The speed of work should be ensured that the patients are also not dissatisfied. But what happens is that most of the time is that we will be typing and we will not be looking at the patient. So earlier, what do you call it? The previous generation, the doctor used to be looking at the patient and then we'll be talking. But nowadays it has reached a stage where we will be typing on the computer and the patient will be just talking. So that eye connect is not there. And eye connect in clinical medicine is actually very important. So all these things can be sorted out to some extent if there is a better speed to the technologies.
Well, let me come back to Dr. Betsy in terms of, because you are part of a teaching process, the next generation who is going to come up. So in terms of medical education, what really is, are we giving time to these students to learn technology? Because I think Dr. Satish in the keynote address was mentioning about teaching doctors AI. I think after 15 years of medical education, nobody will be interested in learning anything else. So it's very, very difficult to teach doctors anymore. So what we need to do is look at whether the IT people can learn a little bit of medicine and help us with that. So what's your opinion? I think that the panel has to comment on that.
I have an exception here, Dr. Mohan. After his DM in neurology, he is a certified AI.
I believe he is an exception to that. I am a plebeian. Maybe Boben will be with me in terms of learning anything is so difficult for me, even typing. Look at the speed at which we type, it is pathetic. So what can be done about that? What's the comment on that, sir?
Yes, okay. Regarding medical education, I don't know whether you're aware, medical education has gone a drastic change from 2019. We call it competency-based medical education. But fortunately or unfortunately, we are not giving much time for health tech. But that is undergraduate level. Postgraduate level, definitely a lot of time. And again, the core values which are impregnated into the postgraduate medical education, it covers all these technical aspects. But personally, I do feel that the young tech-savvy generation won't find it much difficult to imbibe all the new technologies which is happening in health education. Another important thing is, all of us were talking about the touch, the look, the presence. That part is given importance in the new medical education. None of us were taught how to communicate with our patients, what attitude we should have. But today in medical education, we are teaching them attitude, ethics, and how to communicate. Whatever we are acquiring by our digital knowledge, how to communicate to the end user or our patient, that part we are taking care in the new medical education system that we are very proud of also to say that. Thank you.
Thank you. I think we are reaching the concluding part, and if there is time, we can take a couple of questions from the audience if anybody wants to. Can we pass on the mic to? Yeah, sure, please.
So we are discussing about technology on one aspect, and second one is about the cost of healthcare. So even though a lot of technologies have been used, innovations are there, to what extent it is giving the benefit of technology to the poor people? Of course it saves time, but still I feel that it is getting expensive in every day. So that's one thing that I wish to know, whether maybe in the coming days it can be reduced. And second one is about how you are actually using the latest technologies like blockchain, metaverse, Web3.
I think that is a very difficult question for a doctor to answer. I'll pass on the first part of the question to Dr. Madhu if you want to answer about that, and maybe Mr. Saji can take up the blockchain part. I'm sure that we will all run away if you ask a doctor blockchain. Yeah. It will be very difficult.
Years back when Sam Petroda introduced mobile phones to India, many were skeptical whether this is going to benefit anyone. But we know there was one revolutionary change we've made. So in such a way, especially in Kerala, the educated people, we can go a lot. Diabetes is one of the most important diseases. We know every household will have one diabetic patient. Almost 1/5 of the Indian adult Kerala population is diabetic. So for diagnosis of diabetes and to continue the treatment, euglycemia you have to achieve, you should have a glucometer. Simple thing. You can get it at 500 rupees or 850 rupees. And how to use it, everybody knows. Nowadays, every patient is educated on this thing. And this is a simple device, but now we are going further higher, connected devices. Especially when the parents are alone at home, when they are having low blood glucose level, hypoglycemia, they will not be able to identify it. But when we check it, automatically that signal will come, the red light will come. And the connected mobile app, that data is transferred to either to the doctor or to the relative or the caretaker. So that these things are happening. It's it's not at all highly.
Okay, thank you, sir. I'll just quickly, because in the interest of time, Mr. Saji, just comment, and then we have one more time for. I think we'll take it offline. There are a lot of questions. Unfortunately, because we are running behind schedule, the panelists are all available after the meeting. So please feel free to come back to us and ask us offline. Sir, yes.
Yeah. On the cost aspect, my view is that when the technology is being widely adopted, the cost of care will come down. At this point in time, it is mostly some of the corporate hospitals or others are currently using. When the government and when it is being widely adopted, if you look at the digital technologies, we call it exponential technologies, because the way it can impact is exponential, the impact, and the cost will exponentially come down. So that is my view on that. Second thing, in terms of adopting newer technologies, one of the hospitals in Hyderabad recently bought a space in Metaverse to provide, it's mostly for providing patient experience and for educational purposes. That much I know. So I'm also learning on it.
Yeah, one last quick question and one quick answer, so we don't have time for anything else. Yeah.
So, morning everybody. It was a wonderful session, but I wanted to ask this one particular question, because we have care providers. We be technologists, or you being the doctors, we are all care providers in one way or the other. So technology has grown to the point where EMR systems are actually talking to each other via technologies like HL7. But how much do you think is, how mature is the healthcare sector in India to be able to adopt technologies such as EMR, interoperability or interaction? Sir, you spoke about second opinions. But I see a lot of reluctance in our Indian sector where they are not ready to actually pass information from one EMR to the other, so that you can take a second opinion.
I think we get the question in terms of whether you need sort of a legislation also, probably to that extent.
Can I answer that question? So first challenge is standardization. So we don't have standard clinical terms and terminologies being adopted in this country. So my place, it may be a CBC, another place it could be a complete count. So it is to the machine, it meaning two different things. So there is internationally, there is a SNOMED CT, lot of standardization. And in the US, it is basically, it came from a claim processing. So they adopt coding. Right. In India, we don't have that. So that is one. Then the ABDM, that is the Ayushman Digital Mission, is taking it to. There is a government agency, CDAC Pune, NRC is getting this standard being adopted in India. So I'm part of a healthcare IT group. We are conducting training for all the IT professionals together with the CDAC Pune to propagate this idea of standardization in health information exchange, as well as in terms of standardizing the healthcare terms and terminologies. That's in each of these areas. So there are standard terminals, coding standards are there, which is not being adopted. That is the major challenge.
Thank you, sir. Of course. We are short of time. We can come back and maybe.
I just comment on what you have been talking. Actually, yes. That's what. See, here doctor was telling that no, doctors having a stigma of or something resisting to using the technology. Actually, from my experience, I'm into the chronic disease management sector using the technology. Been into the IT industry last 20 years, and I worked for IBM Watson as well. I was part of the IBM team, firmware team, AI team, and that. Thing from the startup experience in India, what I learned that the spending culture. So if you come up with something with new, nobody going to spend for that. From the hospital fraternity, from the healthcare fraternity, this is the same experience most of the startups facing actually. That's what the successful startups in India moving out. It's a fact. It's because the same question here as one problem we were discussing about here. See, doctors needs to look on the monitors all the time. There are solutions for that. You just speak with your patients. The system can detect your voice and understand the things, and it can create the report for you. But none of the hospitals will invest for that, I'm sure. So who is going to change this one? That's my question.
Yeah, and that's an excellent question raised. I think we all need to think about and find answers. So I'll just summarize because we are short of time. Basically, there are two aspects to developing a technology. Is basically to use and look at the end user. That is the most important. Get feedback and second is, it is not important to scale up alone. we have to take the whole community together. We should have the ability to scale down also. If you have small hospitals, the technology should be useful to that hospital also. So these two aspects I want to take it as something that you take home. And I thank all the panelists for giving us the time and your opinions, sir. So I'll stop here. Thank you all for your patient listening.
Thank you. Thank you so much. Dr. N. Madhu. Thank you. Thank you so much.